Good morning, I'm Dr. Lauren Barron. I'm one of the heart surgeons on the structural valve team here at Baylor St. Luke's in Texas Heart. I thought I would go over a little bit about, in a world where percutaneous valve replacements become the norm, when is surgery actually the best option? And I always start with the guidelines, and this is probably the best representation of the worldwide guidelines. The European and the American guidelines, very similar, a little difference with respect to ages, but this is kind of a busy slide, so I thought I'd break it down into something that actually looks like, something that makes sense. So if you are under the age of 65, you live in the United States, and you're low risk, you're a surgical candidate. That's an easy one. If you're over the age of 75 or 80, and your surgical risk is more than 8% for mortality, then you're a transcutaneous candidate, easy. And in between, if your risk is in between, and if your age is in between, then you could go either way. And when you look at this over the span of a lifetime, it looks like we've narrowed it down to a pretty small group of people that we have to make a decision on an individual basis. But that's just not true, because the thing is, most of the patients who need an aortic valve replacement fall into this category of could go either way. So how do you make a decision? And why aren't the guidelines more specific? Well, it's because we don't have the right answers quite yet. The technology is new, and the patients are all very different, so grouping them all together doesn't always work. Let me give you an example. So we talked about the core valve study that says their conclusion was that TAVR is safer than surgery at 30 days, and they have less risk of mortality or death disabling stroke. And when I looked at these two, death or disabling stroke, when I looked at these two lines, I thought, am I comparing apples to apples? Are the red line and the blue line the same group of patients? And on their face, they are. The patients look similar with respect to their comorbidities, their age, and their gender. However, when I looked at what we actually did to these two similar groups of patients, I found that in the surgical group, 26% of them actually had more than one procedure done. They had an aortic valve replacement and something else, like a CABG or a Maze procedure. And I thought to myself as a surgeon, well, I know that if I add a procedure in with another procedure, that those risks are additive. And I wondered, if I plug in these patients into our risk calculator and I get their actual risk, are these results unexpected? And should we maybe not compare the patients who had more than one thing done to the patients who had a TAVR? Well, so I did. I plugged them in, and this is what I got. You can see on the left side that's isolated AVR, and on the right side it's a CABG plus an AVR. And what it did was it increased the risk for mortality by 49%, and it increased the stroke risk by 55%. Essentially, it doubled the risk. And when you look at the outcomes of death or disabling stroke, and you see that at 30 days, 0.9% of the TAVR patients had this outcome, and 1.7% had this outcome in the surgical group, it's roughly doubled. It's exactly what the risk predictor predicted it would be. So I don't know if I can apply the results of this study to every single patient. And it's not just this one thing. Do they need something else done? There are a lot of other conditions that aren't accounted for in the trials. Let me give you some examples. So bicuspid valves wear out faster than tricuspid valves. And until the low risk trials just recently, we excluded all these patients from the trials that we have data on. And so we don't have any data beyond 1 year, and the data that we do have, it's a very small group of people. So we don't actually have the right answer for these people either. When we look at things like heart failure, at the very beginning, in the partner trials, we excluded anybody who had an EF of less than 30%. And in the core valve group, there wasn't an exclusion, but the average EF was 60%. The sad part about this is a study that looked at what happens when you fix somebody's aortic valve with TAVR before they get to become severe if they have a really low EF. And what they found was there was a mortality benefit. So we excluded a group of patients that would have benefited from therapy because we didn't include them in the trials. It's another group of patients we don't have the right answer about what to do with them yet. The other thing that we have to consider is we talk about high-risk anatomic features. Will our coronaries obstruct? Will we have a paravalvular leak? And that is very dependent upon what is the level of experience within your group in the interventionalists who are deploying these valves. And how comfortable are they with assuming those risks if a patient is borderline? Well, basically, this is what the guidelines give us. That's a pair of coolie scissors, or my scissors, and that's a pair of gardening shears. And we all know what to do with both of those things. I'm not going to trim the hedges with the coolie scissors, and I'm not going to, do heart surgery with the gardening shears. And so the guidelines tell us pretty simply who's obviously surgical and who's obviously TAVR. But what happens when the scissors come in all kinds of different varieties? How do we know what to do with all of these different scissors? Well, each of these kinds of scissors are used by a specialist who knows what to do with them, right? A chef, a seamstress, a paramedic. And so the heart team approach is the first line in both sets of guidelines. And it seems pretty nebulous, but when you think about it, most of the patients that we talk about need to be considered on an individual basis, and they need to be considered by a panel of experts. So every Tuesday morning, a group of somewhere between 25 and 35 people meet, all experts in their fields, to consider each patient individually on who's going to have the best outcome with the right kind of procedure. In this group of people, we have cardiologists of every flavor. We've got imaging specialists who warn us when we might be missing something. We have advanced interventionalists who tell us exactly how risky the anatomy is. We have heart failure specialists who will optimize the patient and then tell us what to predict after we change the way that the heart works. We have surgeons who work in access for alternative access. We have 3 of the most experienced surgeons in the world who do advanced redo surgery on a daily basis, who can tell us whether or not they think that this is a good idea, and if those 3 aren't going to do it, nobody should do it. What you have in this group of people is a team that's going to sit down and focus on an individual patient based on that individual. And so that gap of knowledge that we don't have in our studies yet has to be made up for by a team approach. And that's why the guidelines start with every patient who gets an aortic valve should have a heart team. Thank you.